Hypercholesterolemia. Michelle Nelson, MD. Conclusion. MD. Basics. Description. Elevated cholesterol is considered a significant risk factor for atherosclerotic cardiovascular disease, USCD, although the relationship is not simple. Lipoprotein subtypes. Low-density lipoproteins, LDL. Atherogenic. Primary target of therapy. High-density lipoproteins, HDL. Atheroprotective triglycerides, TG. System, S. Affected. Cardiovascular, CV. Epidemiology. 29% of U.S. adults 20 years old have total cholesterol levels greater than 200 mg/dl. 7% of U.S. children and adolescents between the ages of 6 and 19 years have high total cholesterol. Prevalence. Disease incidence and prevalence increases with age. Etiology and pathophysiology. Pathophysiology. Deposition of cholesterol in vascular walls creates fatty streaks that become fibrous plaques. Inflammation causes plaque instability, leading to plaque rupture. Atherosclerosis, inflammation, and vascular reactivity are complex processes not explained by cholesterol alone. Etiology of hypercholesterolemia. Primary, genetic causes, familial dyslipidemia. Secondary, obesity, diet, excessive alcohol intake, hypothyroidism, diabetes, inflammatory disease, systemic lupus erythematosus, juvenile rheumatoid arthritis, liver disease, nephrotic syndrome, chronic renal failure, medications, thiazide diuretics, carbamazepine, cyclosporin, progestins, anabolic steroids, corticosteroids, protease inhibitors, antipsychotics, isotretinoin, genetics. Familial hypercholesterolemia, FH, elevated LDL levels from birth. Prevalence is 1:500 in the United States. Predisposition to atherosclerotic disease in early adulthood and high coronary heart disease risk at younger ages, 40s and 50s. Tendons. Xanthomas on Achilles and extensor tendons of the hands are common. Early lipid-lowering drug therapy has been shown to reduce USCD risk. Early cholesterol testing of first-degree relatives is recommended and beneficial. Risk factors. Obesity, body mass index BMI greater than 30 kg/m2, physical inactivity, heredity, cigarette smoking, excessive alcohol use. Unclear relationship between diet rich in saturated fat and hypercholesterolemia. The relationship of diet to disease is very complex and is not explained by how much cholesterol is present in an individual's diet. General prevention. Regular physical activity. Weight control, see ongoing care. Commonly associated conditions. Hypertension, HTN, diabetes mellitus, DM, obesity. Diagnosis. Screening recommendations, U.S. Preventive Services Task Force, USPSTF, 1A. TC and HDL cholesterol, HDL-C, every 5 years. Men and women greater than or equal to 40 years. No recommendation for or against screening in adults aged 21 to 39 years. No recommendation for or against screening in children and adolescents. American Diabetes Association, yearly dyslipidemia screening for patients with diabetes. Pediatric considerations. National Heart, Lung, and Blood Institute, NLBI recommend universal lipid screening for all children between 9 and 11 years and between 17 and 21 years old. This remains controversial because of the absence of data showing improved outcomes and concern about potential harms. Selective screening of children with FH of premature coronary artery disease is not controversial. USPSTF, insufficient evidence to recommend for or against screening children and adolescents. History review. Possible secondary etiologies, see etiology and pathophysiology. Review medications that may alter lipid levels. Assess other risk factors. Physical exam. Non-specific findings, may calculate BMI and examine for xanthomas. Diagnostic tests and interpretation. Initial tests, lab, imaging, lipid panel. Fasting labs do not significantly affect lab values. TC, LDL, HDL, TG. LDL is usually a calculated value and is accurate if TG 350 mg/dl. Non-fasting labs are an even better estimate of cardiovascular risk. 2. Consider genetic etiology in very high LDL, greater than 190 mg/dl, or TG, greater than 500 mg/dl. Treatment alert. Multiple differing guidelines exist. Patient-centered decision. The 2018 College of Cardiology/American Heart Association, ACC/AHA, cholesterol guidelines return to targeting LDL goals. ACC/AHA and USPSTF guidelines recommend statin therapy based on patient's risk of an ischemic event. Efficacy of statin medication for reduction in myocardial infarction, MI, and death is likely due to mechanisms other than cholesterol lowering alone. Risk stratifying patients should be reserved for primary prevention, as patients with established CV disease should be considered high risk. Secondary prevention. United States, ACC/AHA cholesterol guidelines. 3. 4 groups benefit from statin therapy. Primary elevation of LDL-C greater than 190 mg/dl. High-intensity statin diabetics, type 1 or 2, ages 40 to 75 years with LDL-C greater than 70 mg/dl. Moderate intensity statin risk based on pooled cohort equations. http://tools.acc.org/ASCVD-risk estimator 10-year risk 5%. Lifestyle modifications with Mediterranean diet and exercise 10-year risk 7.5%. Moderate intensity statin, discuss with patient 10-year risk 7.5 20%. Moderate intensity statin with goal to reduce LDL-C by 30-49%. 10-year risk 20%. High intensity statin with goal to reduce LDL-C 50%. Secondary prevention age 75 years. High intensity statin with goal to reduce LDL-C 50%. Adazetimib if LDL is greater than 70 mg/dl after maximal statin therapy in very high-risk patients. Age 75 years. Moderate or high-intensity statin as tolerated. Definition of very high-risk is at least one major event and multiple high-risk conditions. Major events: acute coronary syndrome or history of MI, history of ischemic stroke, symptomatic peripheral arterial disease. High-risk conditions: age greater than 65 years, heterozygous familial hypercholesterolemia, history of CABG or PCI, diabetes mellitus, hypertension, chronic kidney disease, current smoker, history of congestive heart failure. LDL-C greater than 100 mg/dl despite maximum medical therapy. Significant controversy over threshold calculated risk with which to treat patients. Concern that pooled cohort equations significantly overestimates risk. Concern for significant overtreatment. One study shows 96% of men and 66% of women greater than 55 years of age on statins based on recommendations. United States, USPSTF statin recommendations. 1. Adults aged 40 to 75 years with no history of CVD, 1 or more CVD risk factors, and a calculated 10-year CVD event risk of 10% or greater. Low to moderate dose statin. Adults aged 40 to 75 years with no history of CVD, 1 or more CVD risk factors, and a calculated 10-year CVD event risk of 7.5-10%. Low to moderate dose statin. Adults 76 years and older with no history of CVD, insufficient evidence to make recommendation. Many patients treated and medications used in the United States than elsewhere in the world without substantial evidence for improved outcomes. United Kingdom, National Institute for Health and Care Excellence, NICE, cholesterol guidelines. 10-year risk to be calculated using QRISK2. http://www.qrisk.org. If 10-year risk of CVD 10% and no history of CVD, start atorvastatin 20 mg. If 10-year risk of CVD 10% in presence of known CVD, start atorvastatin 80 mg. If estimated glomerular filtration rate 60 or type I diabetes, start atorvastatin 20 mg regardless of risk. Check non-fasting lipid panel before treatment initiation and at 3 months of treatment. Goal reduction of 40% in non-HDL-C. U.S. Veterans Affairs 2014 guideline advises moderate dose statin for 10-year CVD risk 12%, or LDL-C greater than or equal to 190. or DM with HTN or smoking. Alert: elevated serum Tg if greater than 500 mg/dl. Tg lowering becomes primary target until Tg 500 mg/dl to prevent acute pancreatitis. Statin therapy is usually recommended as treatment unless TGs remain greater than 500 mg/dl after statin added. Fibrates may be used cautiously with statins. Increased risk of rhabdomyolysis. Medication therapeutic lifestyle changes are cornerstone therapies to be attempted before drug therapy, diet and regular exercise. See ongoing care. Available data do not support initiation of statin therapy for primary prevention in most adults age greater than 75 years, Alhatel-LT and other trials. Check lipid panel 4 to 12 weeks after starting medication to evaluate response/compliance. High-intensity statin should lower LDL-C 50%. Moderate intensity statin should lower LDL-C 30-50%. Subsequent monitoring not generally indicated unless question of patient adherence. First-line HMG-CoA reductase inhibitors, statins, categorized based on intensity. High intensity reduces LDL-C by 50%. Atorvastatin, 40 to 80 mg/day. Rosuvastatin, 20 to 40 mg/day. Moderate intensity reduces LDL-C by 30% to 49%. Atorvastatin, 10 to 20 mg/day. Rosuvastatin, 5 to 10 mg/day. Simvastatin, 20 to 40 mg/day. Pravastatin, 40 to 80 mg/day. Levastatin, 40 mg/day. Fluvastatin XL, 80 mg/day. Fluvastatin, 40 mg. Bidpitavastatin, 2 to 4 mg/day. Low intensity reduces LDL-C by 30%. Simvastatin, 10 mg/day. Pravastatin, 10 to 20 mg/day. Levastatin, 20 mg/day. Fluvastatin, 20 to 40 mg/day. Pitavastatin, 1 mg/day to be taken in the evening or at bedtime for best effect because majority of cholesterol synthesis appears to occur at night. Effect is greatest in lowering LDL-C, shown to decrease coronary heart disease incidence and all-cause mortality. 1. Although number needed to treat may be very high in primary prevention, depending on risk contraindications, pregnancy, lactation, or active liver disease. Drug interactions, cyclosporin, macrolide antibiotics, various antifungal agents, HIV protease inhibitors, hepatitis C protease inhibitors, fibrates/nicotinic acid, to be used with caution. Adverse reactions, mild myalgia is common. Liver transaminase elevations, alanine aminotransferase, ALT, before therapy to establish baseline. If ALT greater than 3 times upper limit of normal, do not start statin. Routine monitoring is not recommended. Association with increased cases of diabetes. 0.1 excess cases of diabetes per 100 persons on moderate intensity statin and 0.3 excess cases per 100 persons on high intensity statin. Myopathies, considered rare but not well studied. Creatine kinase, CK, baseline reasonable for those at increased risk for adverse muscle events. Routine monitoring not recommended. Instruct patients to report new onset of myalgias or weakness. If myopathy or rhabdomyolysis is suspected, discontinue statin and draw serum CK, creatinine, and urine analysis. Can re-challenge statin at lower dose or different type after resolution of symptoms. Statin intolerance, consider use of a different statin. Dose reduction. Alternate day therapy. A majority of patients who had previously discontinued statins due to side effects are able to restart the same or another statin and tolerate them. Alert: Food and Drug Administration alert. Simvastatin should not be prescribed at 80 mg/day doses due to increased risk of myopathy. Patients who have been at this drug dosage for greater than 1 year can continue if no signs of myopathy. Dose restrictions to reduce myopathy risk include the following. Do not exceed simvastatin 10 mg/day with amiodarone, verapamil, and diltiazem. Do not exceed simvastatin 20 mg/day with amlodipine and ranolazine. Alert: avoid grapefruit juice with statins. It increases the risk of statin myopathy. Pregnancy considerations: statins contraindicated during pregnancy, class X lactation, possibly unsafe second-line drugs are now recommended in primary prevention if LDL-C is greater than 70 mg/dl on maximal statin therapy. 2. If LDL-C is still not at goal with maximum statin therapy and ezetimibe, then consider adding proprotein convertase subtilisin/kexin type 9, PCSK9, inhibitors. Some benefit shown in secondary prevention. Long-term studies demonstrating benefit and harms not yet complete. Statin, monotherapy, 10 mg/day, or ezetimibe/simvastatin, 10/10, 10/20, 10/40, effect, lowers LDL-C. One randomized controlled trial shows combination therapy with statin has small benefit in reducing CV events and CV-related mortality after acute coronary syndromes. Adverse reactions, generally well tolerated. fibrates types, gemfibrozil 600 mg bid, fenofibrate effect, most effective in lowering TG with moderate effect in lowering LDL and raising HDL. More recent studies fail to show benefit in most patients. Contraindications, severe hepatic or renal insufficiency. Possible interactions, potentiates effects of warfarin and oral hypoglycemic agents. Adverse reactions, gastrointestinal, GI, complaints, increased likelihood of gallstones. Niacin raises HDL but no evidence for improved outcomes, should no longer be used in routine practice. Bile acid sequestrant, e.g., cholestyramine, causes significant GI side effects. No evidence for improved outcomes, rarely used. Proprotein convertase subtilisin/kexin type 9, PCSK9, inhibitors, e.g., alirocumab, ivolocumab, monoclonal antibody requiring SC injections every 2 to 4 weeks. Current evidence shows decreased incidence of CVD in secondary prevention without affecting incidence of all-cause mortality. Active research ongoing. Very expensive complementary and alternative medicine. Omega-3 fatty acids and fish oil intake. Sources: fatty fish, plants, flaxseed, canola oil, soybean oil, nuts. Effect mainly lowers TG level, dose dependent, but has some benefit in lowering LDL and raising HDL, although overall CV benefit and mortality reduction is uncertain. Fish oil, no established benefit in outcomes. Advise patients instead to eat fish. Beta-sitosterols and red yeast rice, contains small amount of natural levastidin analog, can reduce TC and LDL. However, there is significant variability across commercial preparations. Ongoing care. Follow-up recommendations: exercise, sustained exercise for 150 minutes per week, increases HDL, lowers TC, and helps control weight. Patient monitoring. Routine monitoring of lipid levels is controversial. Routine monitoring of liver function tests is no longer recommended if initial ALT is within normal range. Diet. Mediterranean diet, which is high in legumes, fruits, vegetables, nuts, fish, and olive oil, is thought to reduce the risk of cardiovascular disease. References: 1. U.S. Preventive Services Task Force. Final recommendation statement: statin use for the primary prevention of cardiovascular disease in adults, preventive medication. https://www.uspreventiveservicestaskforce.org/page/document/recommendation statement final/station news in adults preventive medication 1. Accessed September 28, 2018. 2. Ebel M.H., Shaughnessy A.F., Slauson D.C. Why are we so slow to adopt some evidence-based practices? A.M. Pham Physician. 2018, 98, 12709710. 3. Grundy S.M., Stone, New Jersey, Bailey A.L., ETAL 2018 AHA/AC